Are live. Hi, my name is Sam Guild. I am very honored to be the president of AIM at Melanoma, and we are being joined today by an amazing group at Kaiser Permanente. I first want to thank all of you for joining us. We have people joining us from throughout the US, Europe, Canada, Australia, and so forth. Thank you so much for joining. Thank all of you who are on the Zoom. I just want to give a quick thank you to Takao Trong. She's an amazing person. Not only is she a great doctor, but a great friend. Rachel Coleman, who did a lot of the organizing behind the scenes. Of course, the presenters who are here today from various regions of KP. I can never forget Ann Taylor Garst, our Director of Community Engagement, and Eric, our tech guru. So we are just virtual today. If you are in the Zoom, please put all of your questions in the Q&A. You're welcome to give a shout out in the chat, but the questions should go into the QA. If you're joining us on social media, please feel free to post in either the Facebook post or YouTube, etc. We are recording, so you won't miss out in case you have to step away for a second or you want to share with other people. And one last thing, there will be a survey going out after the event, so please be sure to respond to it. And without further delay, Takao, what are we going to hear about today?
Hi, great to see everyone here. Indeed, a shout out from coast to coast. KP is Hawaii all the way to Maryland and Georgia. I'm Takao Trong. I'm the National Cutaneous Melanoma Program Lead for KP National, and I'm very honored to be here with AIM and my co-chair, Cherry Sue from Kaiser Permanente, Southern California. We are delighted to be back. The last event in Northern California that we had was also our inaugural event with AIM in 2019. Sherry and the Southern California team had an event in last year, and we really wanted to move forward with a national event this year. So we're very excited that we could all have you here with us today.
Thank you, Takao. Thank you, AIM Melanoma Foundation, for providing us with this platform support and today's opportunity to host the symposium. Both AIM Foundation and KP, we aim to provide excellent care for our patients and bring together specialists for public education. We did have an amazing first Southern California Kaiser Permanente Symposium with AIM in 2021. And I hope to continue these type of partnership in the future. I will give us a brief introduction of our agenda today. First, I will have a conversation with Dr. Alex Mender, who is our KP Colorado Regional Specialty Chief for Medical Oncology. We will have a discussion and a conversation about a side effect of immunotherapy versus targeted therapy, the two major group of therapy available for cutaneous melanoma. Then we're excited to bring us a lesson from pandemic. We will have Marie Suga, the director of KP Clinical Trials Program, and Takao Chang, the National Melanoma Program Lead, as well as KP Northern California Medical Oncology Cutaneous Program Lead, to continue this discussion regarding clinical trial. Next, we'll have a lesson in prevention with better self-care with Dr. Rangel. Javier Rangel, who's our KP San Francisco Dermatology and Kaiser Permanente Northern California Dermatology Melanoma Chair. We will then subsequently we'll bring back a panel of melanoma survivors, our patients who receive excellent care in Kaiser Permanente for a question and answer session. Our last session of the day will be presented by Dr. Raymond Liu. He will discuss what it means to be well after treatment of melanoma, and it's a good thing to focus on survivorship. He is our KP San Francisco Medical Oncology and Survivorship Director, and he has a special podcast program, Beyond the Clinic, Living Well with Melanoma. Okay. Finally, Dr. Takao Tron and our AIM president, Samantha Gill, will conclude our program today. Thank you, and we'll move on now to our first session.
Yeah, we hope that this program.
Okay. So let me share my slides. Oh. Share. Does it go now? Share. Okay. All right. Good. Hi, everyone again. Now we're lucky enough to have two major types of treatment options within our reach. Dr. Alex Mentor, the KP Colorado subspecialty director, and I will discuss and have a conversation about immunotherapy and target therapy with a focus on their potential side effects. Sorry, am I not sharing the screen?
I can see the slides.
Okay.
Can you put it in presentation mode?
Okay. Is that better? Okay. I thought I did.
Yes.
Okay. So focus on their potential side effects, some of their strategy to guide patients in dealing with their treatment and their symptoms. Okay. So first we will focus on the immunotherapy, then subsequently target therapy, which are tablets, pills. So what will patient feel in the infusion chair? What are the symptoms they should watch out for? Well, you can experience any of these symptoms. You would need to report to the infusion center nurse, especially with chills, flushing, difficulty breathing, and dizziness. Keep in mind that only very small percentage of patients experience these symptoms. Most of the patients leave our infusion center feeling well, and they were sent home after infusion. Then what should we watch out and monitor for? So these are some examples of immunotherapy. Dr. Mentor, how do you counsel or introduce immunotherapy to your patients?
The way I tend to frame it is that a lot of patients will actually not have any side effects, particularly with the single agent drugs like nivolumab and pembrolizumab. But that a lot of people do have to watch for toxicities that can develop down the road, and that these are toxicities that are associated with an overactive immune system. So, you know, some of the slightly more common ones are itching and rash. We certainly worry about diarrhea in some patients, which is similar in many ways to autoimmune conditions that attack the colon, like Crohn's disease. And then there's a whole bunch of crazy immune toxicities that can attack your endocrine glands, like thyroid dysfunction, and even ranging all the way in rare circumstances to people developing type 1 diabetes. So most people are going to do pretty well. Some people are going to get some mild toxicities. There are going to be some toxicities that are going to develop, and we're going to have to hold therapy or treat those side effects because they can be serious. I guess the other thing I say is that we really don't know in that first week usually if they're going to get side effects, because those side effects can develop in the first few weeks or in the first few months, and sometimes even later. So you really, unlike some chemotherapies that we give where you're going to kind of know in that first week what the side effects are like, I'd say here we're having to kind of wait and hold our breath a little bit to see what side effects will develop.
Yeah. Thank you. Yeah, I really emphasize with my patient as well, like Dr. Mentor, that symptoms may begin anytime, right? It could be within first few weeks, within first few months, and make sure that if you're getting to the point where you need to go to see other specialists, like endocrinologist or you go to see your joint rheumatologist, you let them know you're on immunotherapy. And early detection equals early management, so that will help to mitigate some of the treatment side effects. Also, I would like to add, before the treatment start, I ask the patient to write down some of their baseline symptoms that will help us to assess which ones are new. For example, you have baseline irritable bowel disease, you have baseline sometimes diarrhea or arthritis. So you write them down. So when the nurse asks you in the infusion center, how many times a day do you have loose bowel movements, you will know that this is, even though yours is, it's 5 times for you, but that's abnormal for another patient. It might be a normal thing for you, okay. So at home, you would like some of the common symptoms to monitor are diarrhea, fever, shortness of breath, feeling fatigued, some rash, headache, insomnia. You would like to monitor these symptoms at home. And we do have a many website, and this is one example of National Comprehensive Cancer Network provide a great deal of what side effect to monitor. They have patient education on what side effects patient may develop based on their symptoms. Okay. So Dr. Mentor, when do you use steroids or immunosuppression, or maybe ask a patient to see a specialist?
So I think on our end, just so patients are aware, we're looking at something called the grade of a toxicity. So if someone has diarrhea, we're going to kind of look at their change in their bowels and say, is this grade 1, grade 2, grade 3, or grade 4? Those are things that help us sort of categorize these side effects and decide, is this something that we need to intervene on? I don't think people need to know the grades. I think as a general rule, what we're looking for is this something that's kind of mild and an annoyance, but something they can live with? Is it something that is, disruptive and it's not going to be a side effect that people can deal with over long periods of time? Or is this a real serious side effect that could put someone in the hospital or could be life-threatening if we don't manage it over time? Certainly when you tap into that third category where we're worried about serious organ dysfunction, hospitalization, or even in some cases death, we're going to hold treatment and we're going to usually give them some kind of immune suppression to try and suppress the immune inflammation that's causing that side effect.
Yeah, thank you very much. And we sometimes re-challenge if the side effects is well controlled, right? Okay, so again, this slide is to show that there are some special patient population that may not be excellent candidate for immunosuppression treatments, such as a patient receive organ transplant, patient with uncontrolled autoimmune diseases. And there's very rare side effects, all less than 2%, that may be severe, but should not deter a patient from immunotherapy, a potentially life-saving treatment. Okay, Dr. Mentor, what are some potential long-term side effects, and how do you suggest patients deal with these potential long-term side effects once they occur?
I think to some degree, sometimes we're looking at which of these side effects are potentially organ damaging, like type 1 diabetes, which is very rare. But if you get type 1 diabetes, we kind of know how to manage it. And depending on, the situation with the melanoma, sometimes the melanoma is the greater risk. So we're just going to kind of manage the diabetes and kind of do our best and continue to manage the melanoma with immune therapy. On the other hand, there can be some real serious side effects like pneumonitis or liver inflammation. Pneumonitis is lung inflammation, where if those get real severe, and especially if they recur after we re-challenge, we may not be able to give additional immune therapy. What I tell people also is it's not 100% with any given patient, but some people who develop some of these severe toxicities, even after just a few months of treatment, can still have long-lasting benefit in terms of their melanoma. So we're still working out what the ideal length of treatment is, but for some people where we've had to stop treatment due to severe side effects or treat them with steroids, some of those people are still doing well with good melanoma control years later, even after just a few months of therapy. So it's not always disastrous to have to hold treatment for toxicities in regards to controlling the melanoma.
Yes, yeah, if your disease are improving quite a bit and your patient's appetite for potential side effect, long-term side effect tend to increase, right? If the treatment is working fabulously, right? As far as diabetes, sometimes we ask endocrinologists, especially with pituitary inflammation, just to replace the missing hormones so that patient can continue treatments, not the end of the world, right? So we move on now. Thank you. We can to target therapy. So some of the target therapy available agents are listed right here on the left side of the slide. And some of the common side effects, it's not all inclusive, potential side effects are listed on the right. Some of the more common ones are fever, rash, and could cause photosensitivity and joint discomfort. So Dr. Mentor, how are these side effects different than the immunotherapy agents in terms of length and the types? Yeah.
In some ways, many of the same organs can be affected. You can get diarrhea, you can get inflammation in the lungs, you can get inflammation in the liver. To some degree, there are some differences in the percentages of patients that experience those. I will say one thing that is a big difference is that with targeted therapies, these toxicities tend to be dose related. And so someone who may be having a lot of fatigue or diarrhea or rash at one dose with the targeted therapy, they may do very well with a dose reduction in their treatment, and they may still have good disease control even at a lower dose. So that's something that we usually start out at the FDA approved dose, but we usually feel comfortable making adjustments to that to make sure that this is a treatment that you can tolerate over the longer term. With immune therapy, it's more of a lottery, and there's really not as much of an effect of the dose of the immune therapy. It's either there or it isn't. And we kind of have to manage it with either continued therapy or hold therapy, steroids, no steroids, et cetera. So it's a little bit different in terms of how we manage them over time.
Yeah, thank you, Dr. Mentor. We live in a Southern California sunshine state. So skin toxicity is particularly difficult to deal with. For rash and skin toxicity related to target therapy, there's a variety of them that could happen, like a hive. Some of them look like acne. Some of them are hyperkeratotic, and small percentage of patients get squamous cell carcinoma, very small amount. It will be preferred that these patients are followed by dermatologists while on these treatments, and wear some protective clothing as well as sunscreen on daily basis, especially when they go out in the summer. And Dr. Mentor, what can we do in helping patients to continue these treatments, particular target therapy?
As I mentioned before, sometimes if it's a side effect that it's just going to be difficult to maintain over indefinite length of time or over a year, then we may have to do some dose reductions. For people who are experiencing fevers as a result of treatment, sometimes staying well hydrated and taking Tylenol on a regular basis can help. And it really otherwise just depends on the side effect in terms of whether or not it's a dose reduction or whether or not it is something we just kind of live with for the potential benefit of the therapy. And then I'll also just say it depends a little bit on the setting of the disease. With when we're treating someone who had surgery and we're treating in what we call the adjuvant setting, meaning that we might have gotten all the cancer, but we're not sure. Sometimes there's a sort of a different approach to these toxicities compared to someone where they have stage 4 cancer, and this is really our best chance to control their a life-threatening disease. So you have to look at the setting and sort of how the patient is tolerating it and what their quality of life looks like, and then make adjustments based on that.
Yeah, absolutely. Yeah, it's an adjuvant setting versus a stage 4 setting. You give you may even think about dose reduction adjuvant setting, even a treatment holiday, right?
Mm-hmm.
Certainly. So our last question on this session is, given all these side effect profile in these 2 major class of treatment, do these side effect profile affect your choice of treatment in the first line metastatic setting and also in the adjuvant setting? The long question.
I mean, I alluded to it to some degree. I will say that, and this is going to come up in some sessions later today. It used to be that we didn't know whether it was better to start with BRAF treatment or immune therapy for people who have stage 4 cancer where we need to initiate treatment. We now have some clinical trial evidence that was generated in part by Kaiser and the National Cancer Institute that says it's better to start with immune therapy and then move to the BRAF treatment for people who have metastatic disease. Despite that, there may be some people who have to be on real high doses of steroids or they have an immune condition already, where we're going to have to start with BRAF treatment because we just don't have another choice in that setting. The other thing that sometimes affects how we choose our agents early on is the presence of brain metastases, which is unfortunately something that is relatively more common with melanoma relative to some other cancers. And so sort of our approach to those sites of disease may sometimes affect whether or not we're going with a targeted therapy or an immune-related treatment. And then finally, what are the medical conditions of the patient? If it's someone who already has an immune colitis condition or maybe bad rheumatoid arthritis, or they're on immune suppression, that may push us more towards BRAF type treatments. So anyway, there's a bunch of factors that go into it in addition to patient preference.
Yeah. Thank you. So, Dr. Mentor, you're initially referring to the DreamSeq trial that provide more and more data to support immunotherapy in the first line setting in the metastatic disease setting. Kaiser Permanente participated in the study, so for patients, a follow-up question for patients who are very concerned about toxicity, such as kind of well-controlled ulcerative colitis, how do you decide between one PD-1 inhibitor versus double or 2 immunotherapy agents together?
So I think for me, I'm always looking at sort of how's the patient's overall health and strength and functional status. The combination therapy, especially with ipilimumab and nivolumab, which is one of the more common combinations that we've used, a lot of people get pretty significant toxicity from that compared to when you're using a single agent treatment like nivolumab or pembrolizumab. So I have to kind of look at the patient and think that that they can take some toxicity if we're going to do the combination therapy. And then of course there's the issue of again, how much disease do they have, and sort of how urgent is a response, because the response rates are higher with the combination treatment.
Yeah, thank you. We want to be very clear that you're saying that 2 drugs in terms of immunotherapy are definitely more toxic than 1, single agent nivo or single agent pembro, but almost the opposite for BRAF MEK inhibitor, right? The 2 drugs used together may have the combination may have less toxicity for patients, right?
Yeah,
So,
less skin cancers for sure.
right, less skin cancer. So for adjuvant, in the adjuvant setting, I tend to favor use immunotherapy because I think that you activate the immune system and keep the cancer in check even when you're finished and completed the immunotherapy adjuvantly. However, I do have some patients, especially young patients, who I did use BRAF/MEK as an adjuvant in the adjuvant setting. What are some patients that you would elect the target therapy as adjuvant setting?
Well, there was, for instance, a patient who where we actually tried the immune therapy, but they had recurrent pneumonitis, and we just couldn't give them more. Where we, and then they had a subsequent in transit recurrence that we removed, and we decided to do the BRAF treatment after that. And then again, people with autoimmune toxicities. I agree with you. I tend to prefer immunotherapy in the adjuvant setting, but I also admit that there's a fair amount of uncertainty here, and that the BRAF drugs have been shown to improve survival. And although we're still sort of sorting some of these things out, it's possible that when you have a really good response in the adjuvant setting, that even with the BRAF drugs, that there may be some long-term cures as a result of that. So anyway, I think we're still kind of sorting out how to compare the long-term results of both of those.
Yeah, thank you. And here are some resources and very good education materials for our patients that's available in AIM and Melanoma Foundation, as well as American Cancer Society. And now let me unshare my screen and move on to the next session. No, okay, I think I already unshared. Okay, so, and we are fortunate, very fortunate to have Marie Suga, the director of KP Oncology, clinical trial program lead, as well as our Northern Cal cutaneous melanoma program lead, Dr. Takao Chuan, to present some of our lessons learned from the pandemic and some clinical trials in melanoma as our next session. Thank you.
Well, we're back. Thank you for staying with us. I'm delighted to have the honor to have Dr. Marie Suga here with me, who's a colleague here at our Vallejo Cancer Research Center. She's the medical director of our Kaiser Permanente Clinical Oncology Program, as well as the principal investigator of our NCI Community Oncology Research Program for the KP National Oncology Program. Hi, Marie. So glad to have you here with us.
Thanks for having me.
Yeah, obviously, KPOC is such a long-standing program that we've had here in KP. I love the long history of the trial program. Tell us where's the work for our NCORE now? The expansion to all our regions has been really a tremendous effort that goes back many years.
Yeah, I think we've here at Kaiser Permanente, we've had a lot of research that's been going on for many decades. As you can see, 34 years here in Northern California. In 2014, the NCI National Cancer Institute decided that they were going to support and fund community oncology research programs. And so there was a grant that was applied for, and we got one of 46 designated NCORE sites. And so that allowed us to kind of really unite a lot of our regions together. So we have actually 7 regions across 6 states, so California, Oregon, Washington, Colorado, Georgia, and Hawaii. So that's really been a really great thing that we've been able to kind of come together and really focus on opening and supporting our National Cancer Institute supported trials throughout the nation.
Yeah, I think a lot of work has been done, and our institution, just like others, recently passed through a really difficult time for research and patients. The pandemic over the last few years was so hard. What are some of the strategies that our program utilized to help patients be able to still have access to these treatment options? What were some of the hurdles and successes there?
Yeah, you definitely point to definitely the COVID pandemic did have an impact on clinical trial research across the country and worldwide, of course. I think research really definitely has a lot of rigidity in terms of things that definitely need to occur in a uniform way, so that we can make sure that we can say that they're valid results. So it does come with a lot of regulations and rules that sometimes were very inflexible. And of course, when the pandemic occurred, I think, unfortunately, those rules, really had to be looked at. And I think actually that ends up being a good thing overall.
Yeah.
A lot of the things that had to be revised and adjusted actually were patient friendly. Things that
Many things we wanted to do for a long time, right?
Yeah, exactly. So things like remote consenting, meaning like being able to consent through like a video visit, just like we're doing right now. Being able to do just routine visits, through the video versus having patients come into the office for every single visit for clinical trials. Those types of things really had to be looked at. The NCI really did an amazing job, to really think about some other modifications that could be done, including sending drug, pharmacy drug directly to the patients. And so I think that now that we're kind of past that hurdle, I think a lot of people really feel that a lot of those things were something that we should continue on, not just, during the pandemic, but like, that a lot of those things really did help patients be able to, go on trial and stay on trial. So.
Yeah, that's true. And I think as an institution, we already have so much benefit because, our trials are available across all our sites. In Northern California here, we have 23 clinics. Many of our trials are open at all of them. And so there was already less travel, but people still have to physically come in or, do this and that extra visit. So now it can mirror a lot more what standard treatment and visits might be like. If a patient was interested in a trial today, how should they do it? What would you recommend they do?
Yeah, that's a great question. I think, one thing is that, definitely talk to your oncologist, see what trials are available. One of the things I think maybe is not realized is there's a couple of things. One is that not all studies are offered at every single place, so, I think that is one thing to kind of keep in mind, is that there may be a very different menu of clinical trials at one center versus another. So it may be worth kind of looking around to see, what options might be available if you're looking for a trial. The other thing to note is that, trials actually are very fluid in that they open and close very quickly. And so often, if a trial might be available, one day, 3 months later, it may not actually be an option, and they might have a completely different option available in 3 months' time. So, just because you asked 3 months ago whether there was a trial available, it may actually be different, depending on when you're asking the question. So I think the main thing is to kind of keep those things in mind, and make sure that you're working with your oncologist to really find the right treatments and potentially consider enrolling into a study.
Yeah, I love that. People don't have to disrupt their relationships, to get on study. They can stay with their local oncologist. From our melanoma program, certainly we love the support of the trial program. I love the direction the field and also our program have taken, which is to focus more on survivorship because patients are living longer. So there's 2 studies we have open, and if any of you out there have oncologists approach you about these, I hope your ears are up. We have a trial that's looking at early cessation in melanoma, and you have just heard, not all treatments are, even if they're effective, there's some side effects. So we want to know just how much you should really be getting. The other trial is looking at side effects and patterns, and whether there's predictive factors, and it's an observational study, so you do your treatment as you normally would with your local center, but your data would help us understand this better, and this is the iCheckIt trial. We have a trial that actually was one of the early trials, EA6141, that was looking at whether giving growth factor support with it might decrease toxicity if you're giving a higher toxicity regimen like ipilimumab, nivolumab. Where do you see the program going, Marie? I mean, I love that, we have connected across KP National now, which leverages, all of our population size to look at trials a little bit differently.
Yeah, and I think that there's a lot of great things in the future, a lot of things that are coming up that I think is kind of really trying to capture a more real world scenario. So I think that's really exciting to be able to be part of. I think as you just alluded to, I think, melanoma really has paved the way for immunotherapy. And, now we're just exploring like, how else should we be using it in so many different ways, and so it's such an exciting time to be able to be part of some of these research where they're really honing in on who should get it, how long should people get it, and are there combinations of other immunotherapy that can work even after you've progressed on immunotherapy? So all of these things are so vitally important. And I think there's, even looking at diversity and ethnicity. And one of the things that's kind of unique about our program is that we really do reflect our population in terms of like who we put on trials. And I think that's a strength that the NCI has recognized, because I think really we want to be able to include a lot of different types of people, not just a narrow group of people, because, we want all the trials to be applicable, once we do get the results, so I think that that's been a real big focus, especially in the last few years that I've seen, and we here, have been really good to be able to put patients on with a diverse background. So I think that's something that I really like to see, the trend of these things moving forward for clinical trials.
Yeah, and I'll thank all of you out there who have participated in our trials before. I think across KP National, we had the S1801 study open here in California, in Colorado, the S1616 study looking at which therapy might be better after frontline therapy didn't work, and also was open here, and both really are changing practice for the field. So it's very exciting. Thank you to all of you out there who are supporting trials. Let us know how it's going, and we hope to offer new exciting treatment options for everyone. Thanks so much, Marie. It was great to have you with us.
Thanks for inviting me.
Well, hi, everyone. We had the pleasure of Dr. Marie Suga joining us. She had a direct conflict today, so that was pre-recorded if you noticed. Next, we have the great pleasure of Dr. Javier Rangel from KP San Francisco and our Northern California Melanoma Program Chair for dermatology to help share his thoughts on melanoma prevention. Thanks, Javier.
Hi, Takeo. Thanks for introducing me, and thank you for inviting me. Thanks to the AIM at Melanoma for having me a good presentation and talk. It's nice to be back, and hopefully again in the future in person. Let's see, I just wanted to start sharing my screen here and see if I can share. I'm so sorry. asking me to give permission for sharing. And, all right, so hopefully that allows me to share. And here it is. Okay, so let's see. Present review,
We can see it now.
Can everyone see my?
Yeah,
Yeah,
we can see it
perfect.
now.
Okay, great.
Thanks.
So I'm a dermatologist and dermatopathologist, and it's a pleasure working with everyone on the Zoomer board here in Northern California. I really enjoy the diversity of my different roles. I have kind of different hats, and so it kind of keeps things interesting. I see patients on some days in the clinic, and I see a lot of pigmented lesion patients, patients with melanoma. And I really enjoy that. I really enjoy the patient interaction. And on other days, I am in the pathology laboratory, so I'm seeing challenging consults from all over Northern California, second opinion consults on melanoma, skin cancers, different difficult rashes. And so it just really keeps it very interesting. And so today I just wanted to briefly talk about different causes and epidemiology incidence of melanoma, tips for prevention, and also just like technological innovations and things that have come out recently. So this is, just kind of the things that I see in the clinic or that come along our way in the tumor board. Many of these are patients I've had personally, and so melanoma can have different appearances. It can be very large pigmented lesions, kind of like the one on the left, with nodules, different colors, and very suspicious appearing. Sometimes they can be kind of red or bleeding lesions on the scalp, of uncertain etiology to a patient. They might have thought they traumatized their scalp or something happened, or an injury. So they can really have different faces and appearances. So a little bit about melanoma in 2023. It's estimated that there's going to be over 7,000 deaths due to melanoma this year, and it's really one of the surprising things is it's the leading cause of cancer death in young women, 25 to 30, and the second in the cohort of 30 to 35. So it's very, very common, and something that we're trying to increase awareness about. And so I think that's why giving this talk and giving this cancer prevention talk is I think of key importance. And in terms of like total incidence, there's almost 80,000 new cases of melanoma that are predicted to come out this year. So it's been slowly increasing. Just a kind of comparison, there's really the three most common skin cancers. Really the most common is the basal cell skin cancer. And when people think about this, I tell them that that's the wimpy skin cancer. That's the type of skin cancer that's very, very common, very indolent, slow growing, can take years to really manifest. And really in terms of death and morbidity and mortality, it's much lower. There's very few deaths due to basal cell. Because it can be very surgically amenable, even topically treated sometimes. Squamous cell carcinoma, cutaneous squamous cell carcinoma, on the other hand, is less common than basal cell, but it can have quite a bit of morbidity. They can metastasize and occasionally cause death, and more so in the immunosuppressed populations. Melanoma, on the other hand, is much less common. However, it does account for many more deaths than the other two more common types of skin cancers. So there's the triangles in terms of incidence and deaths really kind of are inverted to each other, as you can see by this graph. And in terms of epidemiology, like I was saying, the lifetime risk of melanoma, it used to be 1 in 50 here in the US. Now it's kind of slowly increasing to 1 in 40 for white persons, but still pretty common for Hispanic and Latino and Asian descent, 1 in 200, and for African American persons, it can be 1 in 1,000. So, people can recall Bob Marley passing away from melanoma. And the risk factor really is higher if you have a family history. So a first degree relative, a sibling, a parent. If you really have excess UV exposure, so a lot of, history of tanning as a child or tanning bed use, 5 or more blistering sunburns as a child. And your immune system status is of high correlation as well. So organ transplant patients, people on immunosuppression. And like I said, I really want to focus on some of the causes like UV radiation, which really accounts for a huge percentage of melanoma. And so the amount of sun exposure, the chronicity of your sun exposure, like, if you work outdoors, if you're an avid outdoor enthusiast, like a boater or a hiker, if you're not wearing sunscreen or being cautious if you go to the beach. I used to live in Pennsylvania, and I would see a lot of people from New Jersey. So the Jersey Shore people can get very, very sun exposed and a lot of sun damage. So some of the causes really the UVB rays. Those are the rays that really account for burning. So they contribute to the sunburns and also wrinkles. But UVA is what's more responsible for skin cancer. It can cause a lot of DNA damage, wrinkles, and UVA is what we use for tanning beds. So that can cause a lot of sun damage in our DNA and mutations that kind of accumulate and lead to tumorigenesis with skin cancers and especially with melanoma. This is a slide that I like to share because there's kind of genetic evolutions in melanoma, and this is a lot of what I deal with in my pathology is determining benign moles from malignant moles and kind of the in between. There's a gray zone. So there's obviously very benign moles that are present at birth or develop as acquired, but then there's very obvious malignant tumors, kind of like the photos that I showed you. But there are these so-called dysplastic or atypical moles that kind of fall in between. They're intermediate, and we're not fully sure if those evolve into melanoma or if they're kind of signs of a risk for melanoma. But we do know that they develop mutations, and so those intermediate atypical moles can have mutations in BRAF and other important genes also involved with some of the driver genes that we know about that are also targeted therapies. But as they accumulate more and more UV damage and more mutations, copy number alterations, they become, invasive, or they can become malignant and then invasive. So this kind of just shows that there's a spectrum. There really is a spectrum. And so, getting back to, how do we prevent this damage? How do we lower our risk for melanoma? Really, the thing I tell people every day in my clinic is, you got to use sunscreen, and I ask what type of sunscreen you use. Really, the best sunscreen to use is the one that you're going to use every day. So, you want to try different types of sunscreens. Like I have quite a few that I try on my kids. Lately, they've been liking these little roll-on bars. They look almost like deodorant bars, and so they're really just easy to kind of paint on. They rub right on. They're zinc, so they look a little bit pasty, but they really blend in pretty well. So really the easiest one, the one that you're going to use every day that you won't forget, I put it right by my toothbrush. I have a little sunscreen there. So just kind of making it easy to remember and placing a few throughout the house so that you just get accustomed to it. Obviously avoiding tanning booths and self-skin exams. I tell everyone with skin cancer once a month, look at your skin, get undressed after the shower, and just examine, have somebody look at your back. And then when you go to the doctor for a physical, undress. I think it's a good thing to have a gown, undress, have them look at your skin while they're listening to your heart, to your lungs. Those are very key moments to really have a sunscreen with, a trained physician. And as I'll mention, there's other tools that can be used. So For sunscreen, like I was saying, really SPF 30, the one that you're going to use is, I think, the best one. And they have UV protective shirts. I just recently went to Hawaii, got some UV protective shirts. You can really protect your skin that way as well. And it's SPF 30 and broad spectrum, water resistant. In Hawaii, they have certain restrictions on the type of sunscreen you can use, but I think really the one you're gonna use is the best one. So these are some tips on how to protect your skin and self-screening, as you really want to look all over your torso, your arms in a mirror, your scalp and neck. I mean, especially if you go to the hairdresser, you'd be surprised at the number of referrals I get from people's hairdressers. Looking just at every nook and cranny, every crevice, once a month, and especially your palms and soles if you're of Latino, African American, or Asian descent. A little bit about appearances, the ABCDs of melanoma, asymmetry. You can really, a picture is really worth 1,000 words. You can really see how irregular versus something that you can cut in half and fold onto each other. And especially if you have borders that kind of look like the coast of Alaska, that's very abnormal. Multiple colors, and especially if you have one that's bigger than a pencil eraser, so the diameter, and something that's evolving. And really the evolution, I think, is of key importance for melanoma survivors, because brand new moles that develop afterwards are an abnormal sign. And technology, I mean, like, if you're going to a primary care doctor, they might not know the exact answer about what you have or the type of mole you have, but really teledermatology, we've been leveraging this over the past few years, even before COVID, but especially now during COVID, and that primary care providers, especially in our institution, are really well equipped to take photographs. They can even take very close dermatoscopic pictures, meaning like a magnified picture, send it to our expert dermatologists. We have really a big team of teledermatologists working every day, analyzing these pictures and providing recommendations, management, even expediting appointments when necessary. So really, this has allowed us really to identify more skin cancers even faster with fewer visits. So it's really the best of both worlds. It helps the patients, help us. It really kind of leverages technology. And there's other technologies evolving. There's full body mole mapping and total body photography. There's AI coming into the picture, and that's kind of helping us prioritize things. So these are things that are being trialed, especially in Southern California. They're really trialing machine learning for prioritizing teledermatology. There's dermoscopy. Like I said, we can transmit these images and give expert advice, and non-invasive gene expression profiling, where like little tape stripping technologies, and we can pick up things without doing a biopsy. And so at Kaiser, we have a large survivorship program among our 4 million plus members, a really fully integrated healthcare system. And we have a multidisciplinary committee that develops tools such as our melanoma tracking dashboard to really meet our surveillance goals and our follow-up goals. So that's been really a wonderful innovation with our group and our system. And of course, with melanoma survivorship, we really want to make sure that we increase the quality of care. We detect new melanomas earlier, and it really improves survival and quality of life. So thank you so much for your time, and I hope you enjoyed this presentation.
Thank you so much, Javier. This was a great talk. I learned a lot. There is so much new technology, really a positive part of the pandemic, I think. I mean, very similar to my talk with Marie, right? That there were many things we wanted to do for a long time, have patients get treatment closer to home, not have to go in and out and wait in line for appointments very long. If the positive part is that we managed to get all that done after, I do really love that. So thank you. I'd like to invite now to join me Dr. Sue, as well as some of our patients that have been on this journey together with us. We'll have Mike Maxwell, Patty Arvin, Marta Gutierrez, and Joseph Reitmeyer. You guys can all unmute yourselves.
Good morning.
Good morning.
Morning, Dr. Trong, all.
Hi. I'm gonna let you guys each introduce yourselves, let us know where you're from, and then we'll get started.
Okay, I'll start. Sorry. Good morning. My name is Marta Gutierrez. I'm from Sacramento area.
I'm Patty Arvin. I'm from Vacaville, California.
I'm Joe. I'm from Riverside, California.
And I'm Mike Maxwell. I'm in Danville, Bay Area, California.
Wonderful. I want to start first with something that I think is a big decision for everyone who has a new diagnosis. Your treatment decision, how did you choose your treatment? And I'm going to ask, start with Mike. And Mike, you had an early melanoma. It was a stage 2. But we know that, there's a higher risk of relapse for that type stage 2, often similar to stage 3. Tell us how you came to decide to do treatment. And I'll share also that you decided to join the trial, the Checkmate 76K trial. Let us know.
Yes, thank you. This was actually my second melanoma diagnosis I had. My first one was on top of my head, where clearly I have very little protection. And my second was on my back, 2 spots on my back. And after surgery to remove those spots, the surgeon approached me the next day and said that there was a trial going on and it would possibly benefit myself, but it would definitely benefit others down the road. And for me, that was a no-brainer. My wife and I discussed it, and to think that maybe, and now as it turns out it does and will help others, it was a no-brainer for us to jump in and do that.
Wonderful. Patty, you also went on a study. You were part of the DREAMseq trial, which looked at either targeting your BRAF with tablets that Dr. Mente and Dr. Sue discussed before, or doing immunotherapy first. And you probably heard that discussion, trying to decide which one we do first, and you did it on a study. How was that, going on a study where it was going to be either or?
I just knew whatever I did, whichever one I started with, I was going to fight this and I was going to do it. And I wanted to help other people to be able to find out more information about this. And it wasn't a hard decision. It was, this is what I need to do. And I need to do it for my family, for my friends, and for the world around me. And so that's why I did it. I started with targeted and then went to the immuno.
Marta, you're a very busy young woman. You're working, you have a lot going on. How was that to have a diagnosis where now you're going to have to consider treatment? How was that?
Yes, it was traumatic. I was in shock for a little bit, a few days. But yes, I knew, just like Patty, that I needed to fight this. And I have 2 little ones, so I and my husband, and they were my strength And I knew that there was no other way but to fight it.
And it's true. I mean, you did it after surgery, as Mike did, where, there's a choice, but it's true. Do you want to do everything that you can, or, do you want to watch and wait?
Exactly.
Joe, how was it for you? And I'll let Dr. Sue take you through that.
Okay.
Hi, Joe.
Hello.
I believe I've met you after the head and neck surgeon sent you into my clinic, right? At that time, you had a parotid gland area swelling, and you had a neck lymph node. So it's pretty obvious where the melanoma was. And you had a rib biopsy that in the bone involved one of your ribs that was positive for melanoma. So came on as a stage 4 metastatic disease. We decided to put you on immunotherapy as first line, even though you also are candidate for BRAF/MEK, like the target therapy. So you were on immunotherapy for about 1.5 years, and last dose was May 2018. And fortunately, you've been no evidence of disease or in complete remission since then. We've been following since then. You're off treatment since May 2018, right?
Almost 5 years.
Yeah. Yeah. So just a question for you, and maybe for the rest of the panel can join us as well. Talk about, you already discussed treatment choices. What are some of the side effects that you experienced with your first line treatment?
I really had no side effects. I had the back pain due from a car accident in 2006. I was hit by a car, but overall, I've had no side effects.
That's great. Mike, Patty, or Martha, any side effects?
I had very minimal nausea, and I found that I had some skin rashing in my wrists and my ankles, and my dermatologist attributed that to the medication. The treatment was killing off precancerous cells, and that was where it was coming to surface. So I had a little bit of joint pain, but pretty minimal, couple of days, and then I was good to go. Never debilitating.
Patty, you had both drugs on the study, right? You started on the tablets and then switched later to the immunotherapy. How was that for you? The experience, because you had a little bit of side effects with one or the other.
Yeah, the targeted
kind
therapy,
of a lot.
Targeted therapy. Initially, I started with the higher dose, and I was very fatigued. I had some rashes, but it was really manageable taking the 2 pills a day, taking them about twice a day. I could do anything, go anywhere, and take my targeted therapy. But then I started having problems, and the cancer moved to my brain. And so I went off the targeted therapy and went to the immunotherapy. I always call it, I always use the first letter because I couldn't pronounce the drugs, but I used Yervoy and Opdivo on the second immunotherapy. And I had 2 treatments, I think it was 3.5 or 4 weeks apart. I had 2 treatments. And then I ended up having to stop treatment because I developed hypothyroidism and type 1 diabetes. And so I had to stop the immunotherapy then, but I had 2 treatments. So both of them did wonderful things for me. It didn't come back in my lungs, and it hasn't come back in my brain. So that's been really good.
Yeah. And what's your life like now? I mean, it's been, I think, 2 years soon.
So I have been on Keytruda. I'm almost finished. 3 more treatments, and then I'm finished. But Keytruda has really helped me to continue living my life. I mean, I had a tough time, and 2020 was probably, I didn't think I was going to live through 2020. And I'm here in 2023, and I go everywhere and do everything I can slowly, one day at a time, tasks very small and everything one day at a time. But I don't stop. I just keep going. I do everything I want to do as much as I can do every single day.
Didn't you just take a trip?
I have 2 trips, 2 cruises.
Yay.
And I'm
that's more 2 cruises than me.
Yeah, and I'm on my way to 2 more this year in 2023.
I want to ask one question because I think many patients wonder when they decide for a trial. You know, both you and Mike had a study and you didn't know which arm you were going to get into when you signed up. Was that a problem for you? I mean, for Mike, for you, it was either potentially nothing. You know, that was against placebo because that was standard for high-risk stage 2 at the time. How did you feel about that?
You know, again, it was more the opportunity to possibly help. And I guess if I hadn't gotten anything, I kind of feel like I must have gotten something because something was causing me to react the way it did. But I felt like, you know, just the opportunity to get in and possibly help others down the road, you know, a year later or however long it was going to take, that really was the attraction. And so it was easy. It was really easy.
Just to follow up on the idea of unknown future asked by Dr. Chuang. So Joe, how do you deal with this treatment stopping suddenly after 1.5 years? We didn't wean you off. We just say, okay, you have no disease. You know, how do you deal with that? And what do you think or do at home that helps you deal with the unknown in the future and follow-ups with oncology?
I just wait until I get an appointment with you or I get my scans. And when the scans say no, I'm all clear, I guess no cancer. But otherwise, I just live life one day at a time.
Great.
Marta, how about for you? I mean, you know, you had surgery, you're technically cancer-free, but you have a lot going on, like you said, you have a family. How is that for you after, like, what does the word cure mean for you?
It's very exciting. I don't show it, but internally, I am so happy and so grateful. But yet I know that, you know, we have to take it one scan at a time. And I don't stress about it. I just don't stress about it. If it came back, I'll deal with it then. But today, I'm just grateful to you because you helped me so much. And yes, just keep living and enjoying every single minute.
Sherry, so should we get to some of the questions? Because I know that I see a bunch of questions in the chat for us.
Yeah. So, okay. So we'll, everyone please add to the answer, especially based on your own personal experience. And that's very, very powerful for our patients to hear. Okay. So I would pick a few questions that's, I think, all of them are very relevant, but I'll pick a few due to the time constraints. So Kathleen Burrell asked our first question. The question says that she developed secondary adrenal insufficiency 4 months after finishing immunotherapy. Is that something you see in patients more and more, or just seeing patients? I believe there is Todd Jung also asked a similar question, had an autoimmune response in adrenal gland on hydrocortisone daily supplement for life, came about 2 months into therapy after Nivo and Ipi combination therapy, right? Neo-Ipi is same as Yervoy and Opdivo, right? So it is very uncommon to have, it's rare to have just adrenal insufficiency alone. And in that case, you may need to do more fancy testing like concentropin stimulation test with the endocrinologist, and they will help us oncologists to manage your disease, right? It's more common as a secondary adrenal insufficiency from hypophysitis, which is a pituitary problem that is a side effect of part of autoimmune side effect from the combination therapy. So the patient often gets steroid placement. Their lab values are followed by the endocrinologist as well the oncologist. If they're rechallenged by the oncologist, they put back on immunotherapy. They may need to check cortisol, TSH, free T4, these labs before each dose. We do recommend them to wear a medical bracelet in case of emergency, and that they may need stress dose steroids during illness, surgery, or infection or hospitalization. Okay. So again, it's not the end of the world. You're followed by the oncologist and the endocrinologist, and you do need to take supplements. Like Patty is taking, most likely managing her diabetes with help of endocrinologists with insulin replacements, right?
Yeah, and give you back what you lost. And if you needed more immunotherapy, this would not exclude you from doing that if you're otherwise well after that.
That's true. Let's see. There's also Debbie Roll. I developed rheumatoid arthritis. She developed rheumatoid arthritis, and it's believed caused by immunotherapy. Yes, you can have arthritis. Most of the time, it's not severe enough to, send to a rheumatologist. Of course, if it's severe, we do ask for rheumatologists to get involved and help us to manage with a stronger immunosuppression therapy. Just to keep in mind, we do not want to shut down your immune system completely, because we want to still maintain the efficacy of immunotherapy. Right, so we want to control it and mitigate it so that you retain the efficacy of immunotherapy, or just mitigate the symptoms of the side effects, right? So if it's mild, we may just give you a very a small dose of steroids with a slow titration down to off, and we can do some intralesional joint injections with steroids as well. Okay, let's see.
I can take your question.
Okay.
Eric Niles asked about what are the current or prospective options for patients with NRAS mutant melanoma. So that's a great question, Eric, and thank you for the shout out. We love that you're doing well, and it's true. We have a lot of trials within Kaiser Permanente, but if we don't, we will find you an option outside if, standard treatment wasn't something that worked for you. And, in this community, we know, right? We want to be part of advancing the field. And so, I think especially patients, like Joe or others who've done it earlier, we know that sometimes we have to travel for some of these treatment options, because they weren't as available before. We love that someone like Mike can do it now closer to home, but we may need to do that. For NRAS, specifically, actually right now, there's nothing standardly approved yet, but just like Eric mentioned, there are several trials out there, one open at UCSF, that are using oral tablets that target the mutation, similar to the BRAF targeted oral tablets target the BRAF mutation in conjunction with MEK inhibition. And it is exciting that they work well for some patients also. So we are definitely very much looking forward to the results of these studies to see how effective they are. You guys may know that some people try to combine immunotherapy and targeted therapy. It can be sometimes a toxic endeavor, but that is something that we may look forward to in NRAS, similar as was tried with BRAF targeted treatments. And so, Eric, that's another thing to look for. Interestingly, for some patients, if you have an NRAS mutation, sometimes they respond almost a little bit better to immunotherapy. There was a multi-center retrospective study that thought that at at one point. It was never confirmed, but just as somebody with a BRAF mutation also should get immunotherapy and benefit from all those new treatment options, someone with an NRAS mutation would be similar. You want to take the next question?
Okay, and there's a question on for Vero, I like your name. How common is it for stage 4 melanoma patient to achieve a no evidence of disease with new immunotherapy options? And if there is an evidence of disease after treatment, how common is there a recurrence of disease? So we're talking about durable remissions, I believe, durable response. It is more and more common because we now have in our repertoire like double agent combined immunotherapy, and they do have we do have more and more data to support that there's a lot of patients like our patient panel living right now with no detectable disease on scans or labs, on physical exams, and there's 4 or 5 year data to show that perhaps even half of the patient can remain alive and doing well, like in terms of survival, right? And some of them are still on these treatments. Some of them are off the treatment completely, like Joe, right? And most of these patients, I would say, achieve these type of response, like complete remission or no evidence disease, because they received immunotherapy as a first line, correct? And Dr. Chong, do you have anything to add?
No, I think, yeah, we have data from several trials, that patients with a complete response do very well. As a caveat on the trials, patients were on treatment for up to 2 years until progression on the initial studies that look back. In a retrospective single center study that was published by Memorial Sloan Kettering, anyone who had a complete response, they just stopped then without looking at how long the patient stayed on treatment, and there the relapse rates were higher. So, for example, this PET stop trial that I mentioned that was open to the NCI is trying to resolve that specific question. How good does your response need to be to stop? How much treatment do you have to get, even if you have a good response, to stop? So yeah, great question. We also have a question for our patient panel from the audience. It says, you talk about living in the moment. What do you do to switch your thoughts from intrusive, anxious thoughts about your diagnosis to focusing on the things in life that bring you joy? I'll have Patty start with that.
Initially, I didn't know how to do anything. When I went low, negative, I didn't know what to do. I just cried and screamed and wrote, journaled, and everything else. But now every time I get that feeling of like scanxiety and all those things, I tell myself, okay, you've got one life to live, and you can do it negatively or you can do it positively. I exercise, I do Tai Chi, I dance, I sing. Anything, when I get down, I do whatever I can do to bring me back from that negative thought. Oh, end life. Oh, this. Oh, that. Oh, another scan. Oh, I don't want to do this too. I'm going to do this. I'm going to breathe through it. I have this quilt back here that I leave on my chair. My friends made it for me. I'm going to inhale courage, and I'm going to exhale fear. And that's my mantra. And I have it up here on my wall, and I have all positive affirmations around my room. I just keep telling myself, you can do this. You can do this. And that's all you can do every day. One day at a time, 1 minute at a time.
I feel like I want to go out and do something now. Someone else want to chime in too?
Yeah, I'll add to that. So yes, same thing. At first, it's very very stressful, very scary, and then you just look at what matters. And in my case, I'm a runner, or I was a runner. I'm not sure if I'll be a runner again. So that brought a lot of pain because my melanoma was on the bottom of my foot, and now I have a scar that is very sensitive. So I don't think I'll be able to. I've tried, and I still have pain, which reminds me that, you know, I just have to take it slow and take care of myself. I've I've started yoga, which I absolutely love, and I walk. So I've just gone a different route. But you know, that little step every time that I take and I feel my scar, it reminds me that I'm lucky to be here. So running is not going to be something that I'm going to be sad about, because now I am here and I could have easily not have been. So yes, that's where I go. I focus on my children, I focus on my faith, and I look elsewhere for that positive energy that I need.
Thank you. Yeah, I remember, Joe, you're wearing a different T-shirt with different slogan every time you come to our infusion center, huh?
Yes.
What was some of the positive messages was in your
Okay,
shirts?
I had a shirt that says, "I'm only here for the sexy nurses." I had a shirt that says, "I love my hot nurse." And you know, I couldn't get the bad word shirt, but as a Christian, I wanted to just promote that, you know, hey, I'm here for the nurses.
Yeah.
So I mean, I had a shirt for each nurse. I wish I could have found one for the doctor, but they didn't have one.
Yeah.
Just lots of prayer, and you know, from all the churches I've been to, and you know, they just, you know, just love me, and it's like got me through it. And family, friends. So family first. No, excuse me, God first, then family.
Then the nurses and doctors.
Then the nurses, yeah.
Nurses first.
Great. So I think it's time for. Do we have time for another
Mike
question?
wanted to say.
Okay.
You know, I'll just dovetail on what Joe just said. It really is about prayer and giving it all up. You know, we took it all in stride. It kind of happened fast for us. It came on fast, and then the surgeries were scheduled very quickly, and things happened really quickly. And so we went from, you know, I was on the road traveling for business and golf and all kinds of stuff. And then all of a sudden, you know, this gets in the way. It's just an obstacle, but turning it over, and you just have to realize it's not up to us. We are not in control. This really brought that home. And so my wife was a rock for me, still is a rock for me. And we just turned it all over to him. And that's what you have to do. You got to and then go one day at a time and take advantage of as many situations. And there's no sense in complaining, because, you know, we have it. I think the four of us will agree. We have it pretty good, despite the punch in the mouth and the punch in the gut. But there are a lot of others that are struggling worse than we are. So take it one day at a time.
Thank you all. It's wonderful that you were able to join us. It's really amazing to hear your stories, and I feel always invigorated by hearing, you know, your perspectives. And I hope, you know, it's a thank you from me, from all of us, for sharing today. Thanks.
Thank you for having us.
Yeah, thank you. And sorry we couldn't answer all the questions, but there's a lot of resources and contacting Melanoma and Melanoma website, and please feel free to connect with us again. And so the last session, right? One of our last sessions. So we'll move on to what it means to be well after treatment for melanoma. It will be presented by our Dr. Liu from KP San Francisco.
Thanks, Sherry. Yeah, it's my great honor to have Dr. Raymond Liu here. He's the Cancer Center Director of San Francisco and the Assistant Professor of our Kaiser Permanente Bernard Tyson Medical School. 1 second, I will share my screen.
Hi, everyone.
And I would like to say that I hope a lot of you will recognize him from our Beyond the Clinic, Living Well with Melanoma. He's in that way our celebrity. It's a podcast series that we've been co-hosting together with AIM, and Ray, I just have to tell you, I have to thank you for all your insights and the guests that you've had. Tell us how it all got started. I feel like it was like yesterday.
Many years ago now. So, Taki, I just want to express the gratitude to AIM Melanoma and to you and the team, Eric, our IT, and all the folks that have helped make this possible. All our speakers, even our patients have been on the podcast, and it's been great, and it's been a humbling and learning experience for me. So I just wanted to express that gratitude. So it all started. It actually started for me as a caregiver for my mom. There's a lot of cancer in my family, and I took care of my mom now. It's been 13, 14 years ago with cancer, and as a caregiver, but also as an oncologist or emerging oncologist at the time, I started asking questions. I always wondered whether there was more than just the science or what was happening with the technology and the fancy new drugs. And I really started asking questions about what it meant to be a caregiver, what it meant to be an oncologist, and what it meant to be human. And so I've been thinking about that. And then you gave me this opportunity pre-pandemic to do our last version of this talk, right? A survivorship talk. And it was wonderful. And unfortunately, the pandemic hit. And what we really wanted to do was to really think about what's happening day to day, to connect with the people just like the folks on this call. And we created this live series and then turned into a podcast. And that was 2021. We did the live series. In 2022, we turned to a podcast. So it's been a couple of years, but it's been wonderful. I'm so grateful.
I love how humble you are. To all you out there, if you haven't tuned in, I'll let you know. This podcast is in the top 30, if not top 20 podcasts on Spotify and under health and wellness. You are in season 2 at this point.
Season 2.
It started out as a video cast for some of you who remember when we first had the kickoff during the 2020 earliest pandemic. But now you're on podcast, and everyone can listen to it anytime. You don't have to log in a specific hour. You can just save it. And I love how this year started. And I mean, I feel like it's very emblematic of the series that I think is so fantastic, because you address all aspects of what it means to live with melanoma and to live with cancer, but also specific melanoma. You had the first one this year, the grieving brain on love and loss, and then functional nutrition for cancer survivors. How was that? Those are very different topics.
I have learned so much from each of these topics, and I want to give a shout out to thank you so much for loving the podcast, for those who do. And we're always looking for new ideas, so let us know. Each one of these topics has sort of, we actually centered, it was Anne's idea, we could center around some books too, some websites. Dion has a fantastic website. And Mary Frances O'Connor has a book about grieving, and I actually learn so much from these. And I'll just give you an example. So some of these themes are coming back over and over again, and whether it's a different topic, I'm hearing the common themes. And so, for example, when we think about nutrition, I really take it back to what are the physical things we can do to support ourselves. And in that case, how is food our medicine? How do we enjoy food? What's the culture that we create around food? And how it can heal us and nurture us. And the physical nature of being there, being present, is really, really important. So sometimes when we're in that funk, it's okay to have an ice cream. Yes, we want to eat right. That's what we're also learning from in other scenarios. So nutrition is so important, but it's really part of this larger physical sense of how do we use exercise. You heard one of our the folks on this call today, exercise as nutrition, or an exercise as healing, nutrition, and also just overall being in the moment, being present, and being well. So I love that about nutrition. Now, in contrast, the grieving brain. So Mary took a different process, and she said, let me understand what grief means from a neuroscience perspective. And it was so fascinating because we start understanding why it takes time, and why it's not just about time, but it's about how we can grow from it, and how our brains form new connections, and we form new connections, and how we can come out of that grief. And so I think we talk about acknowledgement of where we are, and then we talk about some solutions. And often we point to things that AIM Melanoma has to support people. So these are very different podcasts, but they have common themes of healing and growth.
Yeah, and I mean, they apply to so many different situations, right? Whenever I tune in, I mean, there's grief. We all have different grief, and I think after the pandemic, I think everyone will be able to list something that they feel has given them a sense of loss, right? There's the loss in terms of having the diagnosis. There's a loss of persons. There's a loss of a type of lifestyle. So I feel like it's just wonderful to think about that more and have space for that, because in an office visit, that's hard to always grasp at. The priority in the office visit is the medical, but when you're out, you want to be wholly well and connect who you are to all of your life, and who you are is in part also, if you are a patient, what your diagnosis is. So I love that. I love that, this is a continuation for the last 2 years. Like when I put this together, it's like, oh, wow, time's really kind of flown. Looking at all the ones you've done, the two threads that really sort of pulled me in are, on one hand, and I love that actually from our survivor panel just now too, with Mike, Patty, Marta, and Joe, that, the podcast where it's about finding the inner strength in different aspects, either healing through music, food, spirituality, or how to cope with everyday life. How do you see it? How has that been for you to walk through with experts through these topics?
I've learned that being a doctor is more than being a doctor. It's about honoring the experience that's happening. And you heard that in the last session with the folks on the call. And, I want to just finish that theme with what Martha said about, I can't run anymore, but I've done yoga. And I want to just honor that and acknowledge that, because this was an expression of grief of who I was before, right? I was a runner. And yet there was growth from that. There was growth of, okay, now I'm going to do yoga. I'm going to find new experiences to get me past that grief. And we have folks talking about living in the moment. I love that. I've learned so much from that, Takeo, because these are lessons we can learn. These are life lessons we're learning about how to empower ourselves, how to acknowledge who we are, how to be in that moment. And maybe I could just also say something that I've learned a lot, which is there are some emotional things that happen to us when we go through cancer and melanoma and through life. And sometimes we think about the shoulds. This is where social media happens, right? Oh, everyone's so happy. They're posting, everyone's on vacation. It's always like so positive. But what I've learned through a lot of these podcasts is that it's okay to hold this like ambivalent feeling about anything in our lives, right? That just as we have grieving a loss, that we're also trying to form new experiences, that we have, as we get older, that we're losing some function, but we're gaining some wisdom. How do you hold joy and sadness together in the same space? Acknowledge that some feelings can come, both those feelings can come at the same time or at different times around the same subject. And I've learned so much about how to first look internally and say, yeah, those feelings are there, and to honor them, and then find some tools to to move forward? How do we manage the shoulds? How, should do this, should do that. How do we manage the anxiety? How do we manage the ever presence of social media, and how we take some control over that? And one of our speakers said, how do we take agency over that? I love that word.
Yeah, actually, that was the other thread that I found. I think while we are when you exit the clinic, you are out there with your family, with your friends, with your coworkers. As a patient, the reality is there is a little tether that brings you back to medicine and your diagnosis. And how do you manage that? How do you balance the two? Like, it's never going to be fully one or the other, or shouldn't be fully one or the other. So I love all the different stories that you and experts that you gather to discuss these issues. Melissa as being your own advocate, because she's been a practitioner in this field for so long. I love that I heard multiple times today, scanxiety.
It's there, it's real, it is real. It is real.
It's real, we've heard it. And dealing with sun safety issues. I think that must be another mirror from, like you're saying, it's a different part of being a doctor in a way, right?
Yeah, and actually what I want to honor too is that I've realized that our caregivers, it's not, I just also want to acknowledge that right here, which is a lot of the themes that happen are really around a community. So it is around the person that's struggling with melanoma, but it's also the community and the folks around them, and how we can honor our caregivers, how do we build that community, how we can advocate for ourselves, advocate for our loved ones, and how we can remain well together. So I love how AIM Melanoma's really brought the community together for us to talk about things. And Beyond the Clinic is like perfect title for it, because we don't really talk about it. And I'm trying to, what I've learned, is I'm actually trying to bring that to my clinic. And I hope, I know this is oftentimes this podcast for our patients and our caregivers in our community, but I'm hoping also some of our physicians listen to it, because I know I've learned so much from it.
Yeah, and this is a shout out to all of you out there. We love that you're with us. If you haven't listened to any of these podcasts yet, they are on the AIM website. You can go into the archive. You can find them, obviously, and on Spotify, on iTunes. Let us know what you think and share with us topics that you want addressed. I love the chat, because I think many of you did bring up issues that have grown out of these podcasts. And I think it's exactly right. This is a very special community, and to stay connected, sharing these lessons is amazing. Well, thank you, Ray. It's always a treat. I love that you were able to join us. And yeah, like you, I'm very thankful that AIM offers this program, as well as many others, to support our patients.
Thank you, everyone who's listening, and let us know, give us your feedback, and always looking to make it better. Actually, and help you guys.
Give me 1 second. Yeah. All right. Thanks today.
Thank you.
Last but not least, I want to invite back Sam Guild, the president of AIM. Give me 1 minute here just to switch my screens. Excuse me. Okay, great. I love this picture of you, Sam. Well, it's wonderful to have you back with Kaiser Permanente here, Sam. I remember the inaugural one we had a few years ago with your mother here as well. We love the work your family has done for melanoma. If you don't mind, please share with us. It's an amazing story that has brought AIM together.
Thank you. So first, I just want to say thank you, Taka. I love working with you and everyone else from KP, and Ray, you're phenomenal. Just jumped in when we asked for you to take on this amazing program that went long beyond what we actually thought. We thought this was just, for a year, and people clearly love coming to and hearing you and your guests. It's a sad story. It begins with a sad story, as you know. So my sister was 25 in 2003 when she was diagnosed with stage 4 melanoma. Overall prognosis was 9 months, and there was only one treatment option available. She passed away the Monday before Thanksgiving. And my mother wanted something amazing to come out of her diagnosis and passing. And she went around the country and asked people what they needed, what the researchers needed. And what she inevitably heard was tissue. We need to find a cure. We need fresh frozen primary tissue to figure out, why certain people are diagnosed with, diagnosed with melanoma. Why do they progress? Which treatment options? And I think we're now 19 years later. She passed away during COVID, and I have been with the foundation for many years, and I readily stepped in and said, we need to make sure that, again, my sister's passing was for a good reason. I need my mother's mission to find that cure. It needed to happen. And so here we are, like I said, 19 years later, with our tissue bank, collecting tissue, and with working with amazing people like you and Dr. Liu and others to educate people and raise awareness about this disease.
I mean, AIM today does so much work for patients in the field. I mean, you encompass, the globe.
Yeah.
I mean, I want to highlight this. I mean, there's just so many tools. You want to take us through, because I hope everyone is watching. It's amazing.
So we've been,
by the way, it's on, and if you go to your doctors, it's on their doctor's door, so you can take a card and take it home. But we will also send you a link to the website.
Yeah, thank you. So as you mentioned globally, we're very fortunate. We are now a global organization. We are in Europe, Australia. We're probably, I think, just every continent at this point. And a lot of these resources are translated and acculturated for the individual regions. So Anne, who's our Director of Community Engagement, will pop some of those things into the chat and stuff as I move along. But the first is side effect management guides. We heard about earlier all the toxicity that comes along with treatment, unfortunately. And so we really want to support all of you in recognizing and managing those side effects. The longer you can stay on treatment, hopefully we help you improve the overall survival. We really want those treatments to work 100% for you. We have, I want to jump down actually. So we have beyond the clinic, Living Well with Melanoma, but we have an offshoot of that. It's from the clinic to the living room webinars. Ray touched on it briefly. Melissa is a melanoma lead at a cancer center here in the US. And we're fortunate that she can help address your medical questions. And she has her own series from the clinic where she brings in her own guests to discuss several of these things. So, for example, we have someone later this month, her and her guests will be talking about vaccines and what the future of vaccines in melanoma. She also has the ability to speak with each of you. You can reach out and ask general questions of her, and she could help you through all of that. We heard a lot about clinical trials, so important. I mean, although we've made great strides to this point, we certainly have a way to go. And so her and this matching service can assist you to learn about clinical trial options. It's something to think about from day one. And at every treatment decision. And so we could help you find a treatment option that works for you. Hope, oh my God, the stories that we heard from the patients, even I get choked up at times. It's why we do what we do, to hear amazing stories like that. So we have a library of survivor stories. There was some discussion going on about how to, you find support among other individuals going through a similar situation. So we have a peer-to-peer support program where we match newly diagnosed melanoma patients and caregivers with veterans, and they support each other. And then there's our Steps Against Melanoma walks, which is for two really important reasons. One is, again, we need to raise awareness about this disease. We need to, help people learn about how to prevent it, early detection, raise awareness about what they can do to support themselves if they're going through a journey, being around other people. And so our Steps Against Melanoma walks is focused on that, as well as raising funding research money. As I indicated, we have a fresh frozen primary tissue bank. And so the support that we get from those walks, supports that tissue bank.
There's going to be one in the Bay Area.
Yeah, yes.
Right?
Yes, I believe we have a date. Can I announce it?
Oh, please. Yes.
Yeah, okay. So, we have several throughout the country. One of them is in the Bay Area on September 23rd. So we invite everyone to come out. We will have one in LA, hopefully that same weekend. We're going to be up in Oregon. We have multiple locations in Oregon, but with all throughout the country. And well, I believe that's in the chat already, but we'll send links out. Again, it's free, you're not required, but we really want people to come out and join and support each other.
That's wonderful. I mean, it is such an amazing time for cancer. We just heard a State of the Union address to talk about the moonshot for cancer. When I think about, how we can talk about a moonshot for cancer, a lot of it started in melanoma. The fact that immunotherapy was developed as well as targeted therapies advanced in melanoma made a big difference, and that happened in trials. I love that studies that our institution had contributed to and many others, recently published in a really changing, not just how melanoma is being treated, it's affecting how other cancers are treated. So S1801 is showing that neoadjuvant therapy has better outcomes than adjuvant therapy. Even our patients who joined us today, in a few months, next year, they might have been treated differently. And I hope we can continue to improve that. DreamSeq, the trial that Patty was a part of, for so long, we weren't sure what we should start someone on, and we have an answer. But there's still a lot of work to do, right? I know, I asked Sam before, and she said it was okay that I could share that she also herself is a melanoma survivor, right, Sam?
Yeah, so I am. So I was diagnosed in my mid-20s, didn't really know much about it at the time. So certainly got a lesson in life when my sister was diagnosed. But it's part of the reason I am so passionate about what I do, because I have children and I worry about them. And now they have a mother and an aunt who both, been diagnosed with melanoma. So this research, again, professionally and personally, is just so important. And it's why, we offer these resources. But clinical trials played a lot in where we are and the advancements we are today. I mean, very familiar with S1801 and DreamSeq, and huge game changers. But there's still a lot of questions that need to be answered.
Yeah, and so it's great, that everyone is working together to help answer those, either by contributing data, analyzing data, or participating in trials, as we are all grateful to patients who are doing that. Being the organization that you are, how do you think institutions like Kaiser Permanente can contribute? What would you like to see?
Oh, so there's lots of ways. So one, sharing with your patients resources like AIM. So I talked about, just briefly, Melissa, I'll go back and mention her again. Patients are in the clinic asking lots of questions, but are feeling very overwhelmed by the situation. And so letting them know that there are resources like AIM, that patients can come and family members can come to us afterwards and ask their questions. We can, Melissa can discuss how to help manage side effects, questions to ask your doctor about their specific care, maybe possible clinical trials. And so we're supporting the patient, but also supporting the providers as well. You can't be on call 24/7, right? You can't answer the questions all the time. So we can support you and your patient relationship and the communication. So when the next visit, it's a conversation that will really be fully developed. We also appreciate your help, when you guys come to our walks, and show the community that you care about them, you want to support them in and out of the clinic, and also support them and their families during this journey. And so, when we provide those sorts of opportunities, we always encourage centers to come to us, including advocacy in research. S1801 and DreamSeek, my mother was a part of that before I was. And so what's so important about it is that you're including the patient voice in, deciding which research to do, helping to make sure that, there aren't unnecessary obstacles. We hear about some of the difficulties with clinical trials, lots of trips, lots of visits. Those are things that we can hopefully help identify beforehand so that when the trial does open up. And then, of course, letting us know when the trials are opening up and if you need help, finding patients. We have access to a lot of patients. They come to us looking for trials, especially in mucosal, in uveal, those more difficult types of subtypes. We can, if we know that the trials are out there, we can help direct patients to them. So those are just some of the ways that, we really appreciate working with providers.
That's just wonderful. Yeah, I think all of us as institutions want to do better. We've come a long way, but we still have so much more we want to accomplish, like you said. What would you tell other patients?
There's hope. Going back to my own experience, 10 years ago, the idea that we talk about no evidence of disease, cure, the word cure, never used in a discussion. I actually remember the last time I think it was during the pandemic, the worst of it, when I was on one of these webinars with a provider and she used the word cure. Unheard of. The fact that we even discuss that, patients, 10 years ago when I was with the foundation and talked to patients, I was always afraid I wasn't going to see them the next year at these events. And now that is not the case. I actually look forward and I know that I'm going to see people again in person.
Yeah.
I can't express to you how great what a feeling that is.
I was actually just thinking, like Joe, who finished in 2018, for other cancers, when you cure, you stop imaging at 5 years, right? That's like another milestone to think about, for how long and how are we going to watch. When the Moonshot Initiative was announced, I think I don't know how many people know, it's built on President Kennedy's initial Moonshot Initiative. And at that time, going to the moon, I think was very much farther than where we are today with curing cancer, stage 4, because it's already has happened.
Right.
So, that's like you're saying, it's unreal to think of, the word stage 4 survivor, was started in melanoma. So I think it's a really exciting time. I think all of us are grateful to the work AIM is doing. Thank you for today. We hope there's going to be a lot more projects and works that we can do together. Thank you for all of you out there who came today to join us. I'm grateful to my co-chair, Sherry Sue, and Gars Taylor, for organizing, as well as Rachel Coleman here at Kaiser Permanente for us, all our faculty, and patients who came and shared their stories and expertise. Many thanks. Please look out for the link that we're going to be sending you that you can share with friends and family who maybe missed it today. And look for us online, in person, and yeah, in the future. Have a great day.
And I just want to say thank you as well, if you don't mind. I want to thank everybody. I want to thank especially, KP for doing this. Again, it's always such a great pleasure to work with you. And I want to thank everybody for joining us. I know it's different hours of the day for different people, and you stuck around and asked phenomenal questions. I saw some of them getting answered. I think most of them getting answered in the Q&A, so thank you. And again, just a reminder, we are sending out a survey after this. We all look at all of them, and they are incredibly helpful when creating programming, creating new, for future events. So please take a moment and answer that. So thank you, Takao. It's been wonderful. Sherry, I love working with you as well. I want to make sure you get your shout out, and we'll see each other soon, hopefully, everyone.